Thank you very much. I appreciate the privilege of being here. And I will be addressing a question that has received surprisingly little attention. That is long-term survival. People don't seem to care that much about it. And here's the problem: 50% 5-year mortality, 10% per year. We see that in the BEST CLI and the Basel II trials, and the risk of death is 3 times higher than the risk of amputation. But all we hear about is, should you do endovascular or open surgery? Not much interest in whether you live or die. What's more important is that mortality rate hasn't changed for 40 years. How could that be? We have all these markedly advances in diagnosis, treatment, and therapy, and the mortality rate stays the same. Well, during the same time period, people who have coronary disease, their mortality rate has dropped down to 1 or 2%. So what's the difference? Well, it's pretty simple and obvious. Patient comes in with coronary disease, they get their coronaries fixed, and they get treated with medical therapy. You come in with peripheral vascular symptoms, you get your peripheral vascular procedure, and your coronaries are ignored. So, in fact, the guidelines say ignore it. They say don't do any diagnostic testing on the heart unless the patient's having symptoms. So how good is that? Well, it's not very good, and in most current guidelines, they make no mention of coronary disease. Imagine that. They talk a lot about medical therapy for generalized atherosclerosis, but no mention about any specifics about coronary artery disease. So how about a new strategy for addressing problems in patients with lower extremity revascularization? It's simple. Diagnose and treat the coronary artery disease, which is the primary cause of death. Now, how do you know if you have significant coronary artery disease? The standard of care now is measure fractional flow reserve, which tells you whether a stenosis is hemodynamically significant or not. And FFR-guided coronary revascularization is the current standard of care. The chest pain guidelines specifically say that a pathway of coronary CT plus computed FFR is the frontline diagnostic test for patients with suspected coronary disease. Every patient with peripheral vascular disease should be suspected of having coronary disease. And so you use the CTA, coronary CTA, to diagnose coronary disease. Do you have coronary disease, or do you not? It's a very simple question. You can see the plaque. And if you have a 40 to 90% stenosis, well, then that guides you or identifies patients who may benefit from coronary revascularization. So what is the prevalence of silent asymptomatic coronary ischemia in PAD patients? Well, it turns out 2 of 3 patients undergoing lower extremity revascularization have lesion-specific coronary ischemia, asymptomatic. This was also shown in the study from Charlotte, North Carolina, 71% patients with critical limb ischemia. There was a randomized trial in Europe, the Incorporate trial, which used invasively measured FFR to guide treatment following lower extremity revascularization. That trial, unfortunately, was stopped prematurely because of COVID. But in the 185 patients who were randomized, 61% had lesion-specific coronary ischemia. So what about using ischemia-targeted coronary revascularization in patients with critical limb ischemia? There's now a 5-year publication on outcomes. In this study, there were 2 groups of patients: usual care, which is lower extremity revascularization, and then best medical therapy, which is what we do every day today, compared to coronary CT and FFR-CT. And if you find something of significance, then you do coronary revascularization as appropriate, like left main ischemia, proximal LAD ischemia, 3-vessel, multi-vessel ischemia. Those are all guidelines for coronary revascularization. So in the FFR group, 69% had lesion-specific coronary ischemia. 58% had severe ischemia, less than 0.75, 8% had left main, and 40% had multivessel ischemia. So all of these patients in both groups had lower extremity revascularization. But in those with the FFR information, they underwent postoperative coronary revascularization, 42%, either PCI or CABG. And here you see two examples: a severe calcific disease in the LAD with a focal stenosis treated with a stent, or left main and multivessel ischemia treated with a bypass. So what's the outcome? At 5 years, there's a marked reduction in myocardial infarction and cardiac death. Basically, you flatten the curve for cardiac events if you diagnose and treat the coronary disease. 5-year mortality, 50% reduction in 5-year mortality. Again, you flatten that mortality curve. And now that mortality curve in the control group pretty much looks like the best CLI mortality, 50% 5-year survival. Except now if you've revascularized the coronary arteries, you cut that in half. So you have improved 5-year survival in critical limb ischemia patients with selective ischemia-guided coronary revascularization. 76% survival in FFRCT and 53% in control. Well, that's a single-center study. In order to really prove the point, you need to do a randomized trial. And one such trial is currently underway in Europe, the SCORPAD trial. And the interesting thing about this trial, this randomizes patients after you've done the lower extremity revascularization. So you're comparing current standard of care, which is no coronary evaluation of best medical therapy, to now a strategy of coronary CT and FFRCT guided care. So this trial is currently underway, and hopefully in a couple of years we will know the outcome. Thank you for your attention.